I'm May Baker, co-director of Newborn Screening Laboratory at the Wisconsin State Laboratory Hygiene. And my academic home is the Department of the Pediatrics, University of Wisconsin School of Medicine or Public Health. Next slide, please. So before I start to talk, and I want to be sure I give the credit to the credit due. And indeed, and all the effort really is a team effort. And here list Wisconsin Newborn Screening Manager team. And we have co-directors, we have manager, and we have supervisor. Our division chief is quite supportive newborn screening. Next one, please. So this is just to give you a general sense in terms of what a newborn screening laboratory looks like, program looks like, and we do screening for the 7 disorders. And last but not least, we're adding on the spinal muscular atrophy. So I talk about COVID-19 and we'll address in that pandemic, and we trying to get the new disorders implement. And the Wisconsin Newborn Screening Laboratory unique situation is we do both screening and short-term follow-up. Next one, please. And by now, I think everybody heard maybe multiple times. And when we talk newborn screening, not just a test, it's a system. That's actually is very simplifies the process. So we rely on the OBGYN to do some prenatal education, and we run the hospital birthing center to collect a good specimen, and we run courier to get sample to us on time, and the laboratory will do the testing and follow with the short-term follow-up and long-term follow-up. Short-term follow-up in the definition is the screening the babies, you get a confirmatory test, and also the true case get to be cared by conditions, and long-term is really look at the newborn screening efficacy. So it's quite a process. Next one, please. So now we talk about COVID-19. So I actually am quite pleased this slides, because I heard my colleagues talking about the important get leadership support, and I can agree anymore, because I think we get to go, and our leadership made it very clear. Newborn screening operation is essential service, and under this concept, not only we are not being asked to help COVID-19 test, as some colleagues in the nation in current situation. Actually, we allocate the non-essential laboratory staff, for example, in the environmental or in the molecular diagnosis laboratory, and they're actually allocate staff to be trained to do newborn screening just in the situation when we need it, and we can get help. Next one, please. So certainly we done quite a bit of things. So I'm just giving some example here. And first, we know we be sure our instrument in function. So we immediately assess all our instruments, be sure they have a remote access by vendors. Just in case things happen, we can do the remote troubleshooting. And in terms of the staffing plan, we have routine staff plan. Really is we trying to on-site have a minimum staff, and to really at the beginning we only trying to complete a daily essential task, and we do have a short period of time, say non-essential research project, and but SMA is an essential project, so we continued. So we do the remote working and also rotating. And I think Kim said the same thing. So we want to be sure things happen, we still have a workforce. And at some times, we be sure we follow all the guidelines, be sure we have the healthy workforce. And contingent plan, the key things is really is cross-training. And in this situation, not only we have external ones and internal one, and we be sure the different testing area we should be covered. Another thing we've done is it's a little bit different, I feel, is we immediately to check our reagents and consumables and be sure we extended storage the inventory than previously. We do, for example, we previously perhaps a couple months, 3 months, and this time we said, if you don't have 6 months out now before they're out. So we did that. And another unique situation we've done is really, we talk about newborn screening is a process and not just laboratory testing. So we really offer to all our clinicians said, we understand you have to work from home and what's the best we can report to you. So we were able to do the secured electronic system, be sure we can send a report directly. Actually, interesting, this part has been so well received because they can basically anywhere they can get a report. And I think this one will stay, even COVID-19 is gone. So I think some positive outcome from that. And next one, please. So, we talked about planning and action. And so we also very rigorous monitor the outcome. So I think this is just a couple examples because I know I have a limited time to present. So here is the figures. Actually, we have this kind of COVID-19 report every 2 weeks. So every 2 weeks, we look at these figures, see if anything changed. And if you compare the same period of time and 2019, 2020, and I'm pleased to say, really things pretty much stayed the same. So every 2 weeks it's quite a pleasure when you say newborn screening operation stable remained in the same. I think it's comforting. So you can tell the result from reported in the first week of life didn't make change, and laboratory turnaround time is keep pretty good, and 98 and beyond, 98% and beyond. So I think we are in some advantage position. Is I heard so many colleagues talk about if the state have a true screening, so the second specimen to get in can become issues. So the one thing I didn't present here, like sample quality, we stay the same. And even we repeat the newborn screening coming back, the rate is stay the same, but we do hear some clinician and the short-term follow-up personnel talk about a little bit harder, get a family coming back. And so this kind of stories. So next one, please. Oh, I think there missed one my slides, important slides. I have a slides that talk about SMA screening. So that one I did ask not to circulate, but I need to present here. The reason I said don't circulate because that's a part of our manuscript submission. So I don't know what I do with that. I think that's kind of important slide.
I apologize, we don't have that on there. I wonder if it was accidentally taken off since we didn't want it circulated. Do you have that available to pop up on the screen?
If you let me share my screen, I should be able to do that.
Yep, you should be able to do that.
Okay, let me open my file to, I think that's, yeah. Let me quick get my file. Oh, no. I just look in my file and also talk at some time. The Wisconsin, we started implement newborn screening to October 15, 2019. So here I'm almost there. So this, can you see the screening? Okay, good. So I'm going to just quick the ones to the last one. Okay, that's good. So this is our first year experience. So couple things I want to mention. This is our screening algorithm and outcome. I put the two together because the journal, they have limited figures you can put in. So we started the whole year with screening a little bit over 60,000. And our first tier testing is the multiplexing real-time PCR. When I say multiplexing, in this reaction, have simultaneously screening for severe combined immunodeficiency and SMA. We also have the marker to indicate your DNA the quality. So we call it reference gene. So the screening for SMA really is a screening for SMN1 homozygous exon 7 deletion. So if you see the presence of real-time signal, so you say screening positive. So, oh, I said it wrong, screening negative. So it indicate either you have a 1 copy or 2 copy SMN1. And the beauty is this assay will not tell you the wild type from carrier, which is we want to be. And the SMA is relatively common in the rare disease world, and 1 in 11,000, and the carrier frequency is 1 in 50. Can you imagine if we detect the carrier, how many genetic counselor effort we need? And Wisconsin is relatively small. Think about New York. And that's, I think this is, we intended to do that. And if SM1 exon 7 absent, so it means they have a homozygous deletion, and we would do further. So in the whole year, we identify 6 cases. So we do further utilize the technology called droplet digital PCR. It's a very advanced technology. This technology allowed us accurate assess SMN2 copy numbers. Then you may ask, why do that? And because of the limited time, you have to take my words now. It's SMN2 copy numbers is a major phenotypical modifier for SMA. Means you have a more SMA2, you have a less severe form SMA. So that's why I feel very important to have this component in that, because the physician, when you have a screening positive case without the SMA2 copy numbers, it's very hard to communicate with family because you just cannot tell. The kids can be very severe, the one spectrum to another one. Kids may be just quote unquote normal, because if you have 5 or more SMA2 copy numbers, the kids essentially okay. So that's why important. So in our 6 cases, we have 2 cases with 2 copies of SMA2, and 2 cases have 3 copies SMA2, and 2 cases with 4 copies SMA2. So another unique situation we do in Wisconsin is when the physician first time see the patients, they also take another dry blood spot samples. And this specimens coming back to our laboratory, we utilize this as a confirmatory testing. So you also ask why, because we really think the time is essential for the severe form SMA, and the SMA patient with 2 copies SMA2. And this process, you substance the insurance process, and also really provide equity to everybody. Doesn't matter their insurance status. It's a similar philosophy when we do the SMA2 copy and during the screening process. So I'm very pleased to tell you all the cases be confirmed. The interesting is currently certain pharmaceutical company actually provide some free SMA2 copy numbers. Every single one is concordant so far we have done. And actually one result, we reported 4 copies, and another reference laboratory coming back said 4 and greater. They cannot tell the 4 and 5 copy different. So I think really is the SMA screening give us an opportunity really go into some uncharted territory. But I think our experience has been very positive. And so I'm going to stop here and